And our first speaker is Adel Syed, an MPA, and he's the Chief Development Officer at Ummah Community Clinic. Please help me welcome him with a nice round of applause.
Thank you. So as the Chief Development Officer for Ummah Clinic, I help oversee our grants, both our federal and foundation grants, our patient outreach and retention, and also our strategic initiatives. And one of those initiatives was the integration of behavioral health with our current primary care services. For today's presentation, kind of three parts. One is an introduction to Ummah Clinic, the work that we do, how we've integrated behavioral health services, and then a case study of that integration with some of our patients. So Ummah Clinic, for those that don't know, was the first Muslim-founded health clinic in the United States, founded 20 years ago after the civil unrest in South Los Angeles. Now they call it South Los Angeles because it's more palatable. It's South Central. And we started with a group of dedicated Muslim physicians and other students who really wanted to help the community heal from trauma after the civil unrest. If you know anything about the civil unrest, you know that it was not just the Rodney King verdict, but it was a culmination of decades of neglect in South Central Los Angeles with the police department, with elected officials. And that culmination actually resulted in the civil unrest that occurred in 1992. This year actually marks the 25th anniversary of that civil unrest in South Los Angeles. And so there's a lot of things happening to commemorate that this year. And so out of that, these Muslim students wanted to do something for the community and really work with the community. Initially, they wanted to start a mobile clinic, but when they went to the community, they said, look, we don't need a Band-Aid solutions to the problems that are affecting our community. We want a permanent location. So they worked with interfaith partners, other student groups, worked with the County of Los Angeles, and we actually had our building dedicated to us. This is a picture of some of the students that are there. So what do the health disparities look like in South Los Angeles? I won't go through all the ones on the slide, but you can see there. But definitely there's a high risk factor for the patients in South Los Angeles, as you can see, for not only chronic illnesses that are prevalent. You see there's only one physician per 10,000 residents, one pediatrician for 10,000 children. These stats are from the LA County Department of Public Health. And there's poor access to safe parks, quality fruits, vegetables. And so this is kind of where we're operating in, and it kind of sets up the scene for why we started integrating behavioral health and some of the other services that we have at Ummah Clinic. About 31% of the residents live below the federal poverty line in our service area. So who do we serve? We have in total about 6,600 some odd patient lives every year, but that culminates into about 33,000 patient visits. And as a health center, it's how do we keep those lives outside the clinic as much as possible, and so that the care that the patient is receiving is not just in the four walls of their physician's office, but what are all the other services that are important for the patient to see. So kind of a breakdown in terms of ages, males and females, students, and the high prevalence of chronic conditions that we see. About 70% of our patient population is Latino and 25% is African American. Of that, only about 4% in total are Muslims. So we're really there to serve the community that's in South Los Angeles, and that's reflective in the surrounding areas. So what are our different healthcare services that we provide? Family and internal medicine, in particular, that's kind of the bulk of the patients that we see. Adolescent medicine, women's health and wellness. We have, again, behavioral health, and I'll get into that a little bit, and also specialty services. So we're open 6 days a week. We have volunteer physicians who come in on Saturday to see our specialty care patients, so ophthalmologists, cardiologists, endocrinologists, all that come and volunteer their time. And I'll kind of get into why that's important, and I think how it plays into behavioral health as we move forward. So this is how we were currently operating, and then kind of going into some shifts that occurred for us. So originally we were operating as a free clinic up until about 2006 when we applied to become a federally qualified health center, FQHC. Are you guys familiar with that designation? Okay, so most of you guys are. And so with that, you understand that there's 19 strict requirements that kind of come with including quality patient care, but also certain measures and metrics that you have to measure up to. That also necessitates that 51% of our current board of directors has to be made up of the patients that we serve. And so they're really on the ground dealing with the community issues and can provide that feedback to our staff and our CEO. So in 2008, we became officially a federally qualified health center. And in 2014, we became a patient-centered medical home, which is another designation. And with that, we were on the track to be able to provide behavioral health services as fully integrated with primary care services. During that time, and looking upstream and looking at some of the other issues that were happening at the time, we started discussions with the LAUSD, the Los Angeles Unified School District, and the Fremont High School in particular, and the Los Angeles Neighborhood Land Trust. The Los Angeles Neighborhood Land Trust takes open spaces and converts them into parks and gardens in South Los Angeles. And if you know anything about, you probably heard the name Ron Finley. He started the urban farming movement in South Los Angeles, where he takes vacant lots and makes them into farms where people can grow their own fruits and vegetables. And this is important because South Los Angeles is a food desert. The prevalence of liquor stores and corner stores, and also the lack of grocery stores and access to fruits and vegetables is staggering, and you can see that in the community if you walk around. And so we worked with the LAUSD and the Land Trust to open our second location, which is on the campus of the high school, the Fremont High School in South Los Angeles. So this is what the building looks like. Here are some of our gardens and whatnot. Our patients actually have access to the garden as well. So there's a patient side and a community side. Some of our chronic illness patients have a plot of land that they grow their own fruits and vegetables. And so, this goes back to going upstream. And so if our primary care providers are trying to work and our caseworkers are working and saying, you need to eat healthy, you need to do certain things in your own life, but they don't have the access to be able to do these things in their own life, then how is their care going to get better? And so we started this Fremont Garden and Wellness Center with the help of these partners. And so why Fremont High School in particular? The population around there is about 500,000, 2,400 students on campus. This health and wellness center provides both behavioral health services and primary care services to the students on campus as well. You can see the different statistics there in terms of the prevalence of a lot of these diseases, STDs, birth rate, the dropout rates in Fremont. And so the school really wanted to work with us in terms of how we get these numbers down. What's also interesting about the Fremont Community Center is that we have two entrances, one for the students that can come in during school hours, and the second for the community at large. And so we also have behavioral health therapists who are stationed there to work with students directly, interfacing with their primary care providers. This is just kind of before and after, so this is what the lot used to look like before we took it over and added the garden and the wellness center. Here are some of the fruits and vegetables and the plants and the flowers. That picture is a picture of our student health leaders. These are ambassadors, students from Fremont High School who work both with their peers and the community at large to help them navigate healthcare services. There are paid stipends every month, so they actually have to go through a rigorous screening process on board. We do a six-month mini public health school during the summer to get them updated on different talking points and items that they can discuss with their peers. We have a curriculum developed. If any of you are working with students in these areas, I'd love to share that curriculum with you so you can take that to your own communities. And again, this is what the Fremont looks like now. Obviously, getting health coverage in that area is difficult. 30% of our patients are uninsured, meaning that there's no reimbursement for us in terms of grants or any federal subsidies. And so for that bucket of patients, we actually go to foundations and our private philanthropic support to cover those gaps. We help each patient that comes in get whatever coverage that they can. In LA County, we actually have a program called My Health LA that subsidizes care for the undocumented community, and so we're able to draw upon some of that money. But again, in general, about 30% of our patients and residents do not have access to health coverage. It's just talking about our health coverage. Okay, so getting into the behavioral health side, I want to talk a little bit about first what the research says about primary care. about 70% of all visits in primary care involve some type of psychosocial factors. Primary care providers are oftentimes the de facto mental health and addiction disorder providers to over 70% of the population, and close to 80% of patients with depression go to the primary care physician first. And so a lot of our physicians are not only physicians, but they're dealing with other issues as well when their patients come in, and they're able to build that rapport. But obviously, there's only so far a physician can go and to be able to provide the type of primary care that they need, and there's often a gap that was there in terms of behavioral health services. And so what are the different types of models of integration? Well, we have just kind of 5 different models that we saw of integration. One is the separate space model, which is kind of the traditional behavioral health model. Then the referral would be given by the primary care. Here, come go see your behavioral health therapist at a different time. We had about a 40% no-show rate for those type of appointments. And then there's the one-on-one referral relationship. Again, same sharing of that relationship between primary care and behavioral health. You have the co-location where they're on site, but they're separate teams, and so they're not really talking to each other. They might just give a referral on site, but they're not actually really talking to each other. You have collaborative care, which is shared cases, right? So the primary care provider will do shared cases with the behavioral health therapist. And then you have the fully integrated model, which we're working right now, where the primary care provider is part of the team in terms of the behavioral health team in getting services for these patients, and there's a warm handoff that takes place for our patients. Clicker died. No. Should I click out of it again?
Did it click out?
I don't know. I think it's on 2 different screens.
It is on 2 different screens, it looks like.
There we go. Yeah. Thank you. So what is the actual behavioral health workflow for our clinic? As you can see, we wanted to get to the full integration part. And previously, our services were co-located, and that really didn't work out for us. It's really a collaborative approach to primary care. We're addressing the entire person. It reduces the stigma of seeking mental health care because the primary care provider oftentimes has already built that trust with the patient. And so they can ask them probing questions, and when they feel it's necessary, go next door and get the therapist to come on in with them and do a warm handoff, literally a warm handoff for that patient. It's really important that the therapist is part of the primary care team originally. And so I would implore you, if you're working with private physicians that give you referrals, or if you can create a connection with either physicians who provide primary care to Muslim patients who are then therefore looking for Muslim behavioral health services, to be able to connect with them and try to build that rapport, and so that warm handoff can occur. Again, the internal referral is the practice where the provider themselves, the medical provider, introduces the patient to the therapist in real time. So there's no come back and the person will see you. If there's acute patients, they're actually able to see them right then and there for maybe a 30-minute appointment. The difficulty in that, again, looking at the operations side, is that we're not able to bill for those patients that same day. And so we have to be able to schedule a follow-up appointment. But we've seen that the no-show rate for those follow-up appointments is significantly lower. About 80% of the patients that we had to schedule after they've had a real in-time person touch have come back for a follow-up appointment and have followed through with both their primary care recommendations and their behavioral health recommendations. So what is the model that we're working with internally? Our CEO, Dr. Vega, kind of put together the SYNC model. So one is screening, so being able to work with primary care providers so they can provide accurate tools and give them accurate tools to screen for any traumatic life events. And so then there's the integration part, so really bringing in the primary care providers and the teams and the behavioral health services teams, look for evidence-based practices, That includes substance abuse, case management, and navigation support services. So we work with case managers as well. And so once the patient has been assigned to a therapist, they're also assigned to a case manager who's working with that therapist to see what other social services are needed for that patient. Definitely non-judgmental, and we address both internalized and external stigma and culturally responsive care. And I want to say it really takes a team effort to make this happen, and there's multiple efforts. And I would just like to, based on our experience, give the following advice. One, you have to have a strong foundation in working with, in committing and educating not only the primary care physicians, but also the behavioral health therapists in terms of what case conferences and working in coordination looks like. Creating a plan in terms of workflow, this is more operations-based, and then pilot project, looking at a needs assessment to see what supportive services are needed in addition to the behavioral health services. And then doing a PDSA or a Plan, Do, Study, Act model where you kind of test at the micro level before you scale up. For our context, we've also worked, for example, with Muslim physicians who are in private practice. Many of the physicians in California, and I think it's different for the Midwest and East Coast, are not affiliated with hospitals in terms of day-to-day practice. They have private practices. Sometimes they see Muslim patients, but they're able to give us warm referrals as well, or warm handoffs as well, and then we're able to connect that patient with a Muslim therapist in return. So I would say if you can, in your community, and this is an issue that you're dealing with, really build rapport with primary care physicians. If they're in a bigger networked hospital system, there's obviously HIPAA violations and rules and things that you have to jump over. But if you're on one-to-one, if you can have a memorandum of understanding, being able to have warm handoffs, I think it makes for better coordinated care. And so what do we do in our case study? And specifically, we looked at a retrospective review of our medical records where we identified our African American Muslim patients who receive our primary care and or behavioral health services. And then once we identified them, we had a case conference where we looked at how the patient navigated the services and the journey, and what kind of things that what lessons we could draw from that. So what do you find? What we found was that there's three kind of prevalent factors in our case study. The first is PTSD, or post-traumatic stress disorder. Many of our African American Muslim patients come from West Africa, and so their immigration journey was part of why they kind of internalized some of their issues. Stress, some of the uncertain path forward, and I think a lot of this was discussed yesterday in some of our sessions, especially on Black psychology. Navigating new systems, including health services. I think just navigating health services and access to health services is such a difficult task. Again, we saw stigma. I think stigma is also a big one, both internalized and externalized. Discrimination, rejection, labeled the other, and then a lot of discussion yesterday was on the intersectionality of identities, of who they really are in the community. So these are the kind of big takeaways that we had with our patients. And then we found that they're kind of stuck in this cycle, right, of untreated psychological or mental illness, some type of trauma that happens, stress, right, in the acculturation process, community trauma or other institutionalized trauma that takes place, and then mental health stigma and the lack of resources. And this vicious cycle that kind of continued to plague many of our patients before we were able to integrate behavioral health services is how do we really break this cycle and be able to provide the type of care that they need. And so I guess for us is really looking at the untreated mental illness and psychological trauma. And because the primary care providers were already in with the patient, we decided to be able to integrate those services with our patients. Again, it's not just the care teams. If you're working within an organization, be it specific to mental health services or primary care, I think it really takes an organizational effort and on the part of management in terms of the therapist, in terms of working the entire team, and to make your I guess workflow as trauma informed as possible, based on the understanding of triggers. And I think sometimes when we went through a training with our primary care providers, oftentimes there were re-triggering trauma for many of our patients and not fully understanding, for example, the way they're questioning or dealing with their patients. And so to be able to sit down with them and tell them, maybe you can take a different path in terms of when you're questioning, or when is a good time to bring in the therapist to really work through some of the issues that the patients are dealing with. And so that was really important for us, that it just didn't happen overnight. And I would say working with other organizations or folks that are trying to integrate a myriad of services, that you really have to have multiple people at the table, that you can't operate in silos to get patients the best care that they need. So what do we find in terms of our case study, in our case study? I think it's important that we begin to address the gaps for specifically African American Muslims in the mental health care provision, and we would argue that the primary care provider is often a good gateway into that. Each community is different, and I think we understand that. For example, what works for us in South Los Angeles may not work for the community that you serve, but I think it's important that you look at the local demographics and see how you can integrate it as best as possible. I think behavioral health and primary care in terms of tracking patient goals is important. So we've been doing this now for about 1.5 years. We have a longitudinal study that we're going to go back and look at to see if the prevalence of chronic conditions once the patient has both behavioral health and primary care has gone down. And I fully understand that, in coming with my funding hat on, that foundations, grants, and just some different government grants, they kind of have two tracks, right? You're looking at primary care, or you're looking at behavioral health and mental health. And oftentimes the funding is very tied down to that. But if you can really strongly make a case, and what we're beginning to do is that the integration of these services provides for better health outcomes for the patient, you'll have a much stronger case in terms of being able to bring in additional services and talking about strengthening your own provision of care for patients. So the quote from one of our board members, and with that, I'll leave it up to questions and answers. Thank you.
What challenges did you run into the most initially, and what challenges, if you want to do something like this, or any outreach to the community, do you think that you should look out for?
Sure, I think for us in the beginning there was, and there still is, a lot of stigma around seeking mental health and behavioral health services. And so we really had to go and find out where people will congregate, right? So we work with the local churches, we work with the local neighborhood councils, and to really kind of slowly do some presentations about what it means to have proper behavioral health services and whatnot. And then again, I think working with primary care physicians and talking to them about the need for this, or different screening tools that are available. I think the sister mentioned yesterday in one of the sessions that you don't call it behavioral health services or mental health services, right? If you're doing, for example, group sessions, we call it a group cafe, right? And people can come and share ideas about different struggles that they're going through. So you do a group therapy session and people don't even know they're in a group therapy session oftentimes. So I think it's the messaging around how we're doing it, and then going to places where people already congregate, where there's built-in trust, working with those organizations and that leadership to be able to say how this is an added service to people's lives and how they can get better. I think what else also worked for us is that, look, we can stand here and give these presentations and talk about this, but our greatest ambassadors are the patients who have benefited from this. And so we don't, for example, go out and make these pitches. We have our patients, and the ones who are able to get trained up and want to help participate, go out and speak on their experience, for example, of saying, hey, you know what, I went to go see my primary care provider, and they told me this, and I didn't really think I had a behavioral health or mental health issue, but when I talk to someone, it helped me work through a problem, and they'll give a real life example. And so those kind of two things have been helpful for us.
I have a question for you here.
Yeah.
Given core systemic issues with prejudice against African Americans, do you connect patients with legal resources or any resources outside of the medical health spectrum?
Yeah, there's been a big movement, specifically in Los Angeles, for medical legal partnerships. So there's a lot of slum landlords in Los Angeles, as there are in a lot of places around the nation. And so, for example, we have a lot of patients with chronic conditions that can be caused by, for example, asbestos in their homes. And so we have a light referral system for medical legal partnerships, but it's something that we would like to explore further. So if you have any takeaways on how we can bolster that support, please do let us know. But again, it's really the case managers who are that kind of reference point, and I would say If you've never worked with a case manager, if you've never thought about bringing one on to your organization or whatnot, really talk with them. They can help you navigate those services for the patient, because there's only so much each organization can do by themselves. You really need that team support of organizations in the community.
Yes.
So I'm a teacher in Southwest Detroit, and so all of my students are African American. And one thing I've noticed in terms of like trauma is they're very desensitized to it, and like not desensitized to trauma. They experience trauma to the point where they're desensitized to like violence and loss and grief and all of those things. So, like, what advice would you give somebody who's like not working clinically with like an African American population in general in terms of like creating spaces to just like digest and make it less of a norm, I guess, like make it more, like give people a space to like recognize that like this is in fact something that is like painful and big and something that needs to be processed.
That's interesting because we ran into that problem when we first started our student health leaders program. And so these are high school students from the community that oftentimes face this trauma and kind of normalize it in their own lives. And so when when we had kind of roundtable discussions, I think for us, because you gotta have, number one, create that safe space and have it be able, have students be able to share their experiences, and then bring in folks who can really talk about this and say, this is not normal behavior, and this is how things should be. And I think those students then became our greatest ambassadors, and I think it's all about empowering, I think, the folks that you're working with directly, and that's what's most worked effectively for us.
Yes. Go ahead.
You gave a lot of information in the presentation. I really appreciate it. So I'm not sure if I got this right, but at the beginning I thought that you said that 4% of the people you serve are Muslim American. Is that right?
Yeah, but in our total patient population, yeah.
So I'm assuming a large percentage of them are Hispanic.
Yes, of our total, yeah.
Are you finding really huge differences in the needs between those populations? You know what, I would think there'd be a lot of overlap in the kind of needs that they're bringing to you.
Yeah, for this particular case study, we just looked at our African American patients, but we do have Latino patients that we also work with as well who are Muslim. I haven't looked into that, but yeah, there probably are a lot of similarities that we can take away. So I don't have an exact answer to your question, but there are, and because our patient demographic is so diverse, right? It's not just one particular type of patient, from one ethnicity or religion or whatnot. And up till recently, we didn't really capture religious affiliation at the clinic, and we've started to do that now in some of our needs assessments and surveys. And so those people who choose to self-identify with a certain religious practice or a certain ethnicity, we're able to track better. But yeah, there most likely is a lot of overlaps.
Yes, please go ahead.
I want to clarify a couple of statistics that you gave us earlier in the presentation. First of all, thank you. In the beginning, you said that you guys had a 40% no-show rate for the majority of patients coming in for primary care, and then you said it jumped to 80% of that same population would show up following seeing a therapist.
Yeah.
Alongside seeing a therapist. So was that dramatic of a jump?
Yeah, it was that dramatic of a jump, and we saw that because, and we kind of asked the patients why, and I think a lot of it had to do with the case manager being assigned right when they came in with the primary care provider. And so when they had a warm handoff to the therapist also said, we want to schedule a next appointment with you, and also here's a case manager, right? So a case manager had more contact with the patient before they had to come in, which included a reminder call or a text, hey, you have an appointment, can you come in? Do you need transportation to your appointment? And so a lot of those issues were mitigated. For example, a lot of the no-shows that we have, even on the primary care side, people just forget their appointments, don't have adequate transportation. About 50% of our patients take public transportation to get to our clinic. And the average time to get to our clinic for them is about 40 minutes. And in Los Angeles, where public transportation is not the bastion of travel, yeah. And so there was a lot of gaps, but because they had better reach to a case manager who could help them literally all the way up until their next appointment, like a month later, it jumped so significantly for us. So that's why we're trying to provide more transportation service and investing infrastructure on the supportive services side.
I have one question.
Sure.
Yeah, go ahead.
Is this in any way similar to was similar to that? Do you guys have this constantly? Or is this something that you guys have short term where you have a case manager who can be assigned patients?
No, this is a constant need for us. I mean, now, we've got an additional grant from HRSA to integrate our behavioral health services and do the warm handoffs. I'm not sure about maybe there was a pilot that you're talking about, but a lot of the clinics in LA are trying to do this and kind of making the case to funders, especially because, the reimbursements aren't as beneficial for a clinic in terms of purely operations speaking. And if you can imagine, when you're doing the warm handoffs, you lessen the provider productivity, and so they're able to not see as many patients per hour because it takes a little bit more time, and so we're taking a financial hit, so to say, for that. And so how do we cover those gaps? And so we're looking at other innovative ways to do that. And it goes all back to workflow, right? So how is from the front office, from the medical assistant, can they maybe see some telltale signs that this person might need to see to provide, up until they get to the provider who can actually make that determination. And so then we can make the workflow go a little bit smoother. But I think a lot of clinics are having a difficult time really operationalizing it. But I think there were some pilots out there, and we looked at some of the local clinics as well.
We have that in Michigan where PCMH clinics, primary care physicians would have social workers for like a year.
Okay, great.
They got reimbursed for
For that, okay. I'd love to talk to you after about how that worked out.
I think you had a question.
How many staff does the clinic have?
Sure. So we have full-time staff, including administrative staff. We have 53 full-time, and we have 9 full-time providers. So that includes MDs and nurse practitioners.
How many social workers?
We have 2 social workers. We have, in addition to that, 2 LCSWs on staff. We contract with psychiatrists. We don't have psychiatrists on staff. The job market in LA is kind of crazy. And then we have about 4 caseworkers.
Any other questions?
Do
Yes.
you provide any consultation and assistance with grant writing outside the organization?
Yes, we do. We're just starting a capacity building arm to the organization. So it's interesting. We started working with FARA 2 years ago. For example, we did a conference in Chicago called the American Muslim Health Conference, but it was for Muslim-founded clinics in the United States. And believe it or not, there's now upwards of 50. Either working with local masajids or mosques, or that are kind of just volunteer run by physicians, and some of them provide behavioral health services as well. And so we did a technical session in terms of, if you want to become FQHC, here's a path you take, here's a free clinic path, here's a collaborative model where providers kind of share their network and Muslim patients are seen pro bono, so to say. And so we did a technical training onto that. For next year, for next year's conference, I was talking to Farah about doing 2 separate tracks. So one kind of the Muslim Mental Health Conference track, and the second one more technical in aspects, so grant writing, theory of change, logic models. We can bring some funders to the table to have some discussions, some healthcare funders to provide those services. But we do that as a consulting on the side as well. I have more information. I have some annual reports and some brochures I really don't want to take back in my carry-on, so if you could please take one and take a look at it. Appreciate it.
Any other questions? Let's give them a warm round of applause, please.
Thank you.